We all know exercise is fundamental to good health.
Hmm.
I mean, doctors recommend it. It's key for well-being, pretty much the cornerstone of a healthy life.
All right. It's seen as universally positive.
But what happens when that dedication, that drive for fitness maybe goes a bit too far? Can pushing your body actually turn harmful? Maybe even sort of compulsive?
That's really the tricky question we're digging into in this deep dive. Can too much of something supposedly good for you actually become detrimental? Take on characteristics we usually associate with, well, addiction.
And our guide for this is a specific source one of you shared, thank you for, that it's a review article from a medical journal in Turkey published back in 2012.
Yeah.
Titled Exercise Dependence by Erdal Vardar. And a review article like this is interesting because it pulls together the research, the clinical understanding that was available then in 2012. Gives us a snapshot.
Exactly. So our mission here is really to step back to 2012 and understand what this specific article tells us about exercise dependence. How are they defining it? What features did they see? How do they suggest identifying it?
And how it was being talked about, especially compared to other dependencies, even if it wasn't, officially classified that way at the time.
Precisely. We want to see the picture as presented in this source.
Okay, let's jump right in then. How did this 2012 article actually define exercise dependence? What were they really talking about?
Well, the article defines it as a condition involving excessive exercise. But the really key part of their definition is that this excessive behavior leads to a deterioration in the person's physical and mental health.
Okay.
And it significantly impacts their overall well-being. It's really the negative consequence that shifts it from just being healthy to being a potential problem, according to this view.
Gotcha. So it's not purely about how much you exercise, but the harm it causes. And the article suggests this idea wasn't completely new, even back in 2012.
Right. It does note that earlier terms had been floating around to describe similar kinds of patterns, things like running addiction, morbid exercise, or even the term running anorexics.
Wow. Running anorexics, that's pretty stark. Gives you a sense of the connections they were maybe seeing early on.
It does, and it hints at how the concept was evolving.
And this wasn't just limited to running, was it?
No, the article makes that clear. While maybe it was first really noticed in endurance stuff like long-distance running, the pattern could show up elsewhere. They specifically mention bodybuilding.
Oh,
it's more about the compulsive nature and the negative impact of the exercise itself, whatever the specific activity is.
So how did the source describe the core experience for someone struggling with this? What does it feel like?
At its heart, the source talks about an excessive desire and this real compulsion to exercise. A key feature is continuing to exercise even when it's clearly harmful, like, pushing through an injury when you shouldn't.
Right.
And crucially, feeling bad, experiencing negative effects, distress when they're prevented from exercising.
That feeling bad when you can't exercise. That sounds an awful lot like withdrawal, doesn't it? Which leads us straight into a major theme in the article. Is exercise dependence really an addiction?
Yeah, this was definitely a big part of the clinical conversation around 2012, according to this paper. The debate was really about whether you could apply the term addiction accurately to behaviors, not just, substances you ingest that cause a clear biological dependence.
So they were thinking about it alongside other kinds of behaviors people were discussing.
Exactly. The source kind of puts exercise dependence in a category with other behavioral things that were being talked about then, stuff like internet addiction or gambling addiction. They were seen as possibly sharing characteristics rooted in compulsive or impulsive behavior.
Okay, that makes sense. And were these behavioral concepts, including exercise dependence, actually recognized clinical diagnoses in 2012? Were they in the official manuals?
The article is very clear on this point. At the time it came out, exercise dependence and these other similar behavioral dependencies were not included in the big diagnostic classifications, like the DSM-IV-TR from the American Psychiatric Association or the WHO classifications.
Right, that's really important context for understanding where this article was coming from. So if it wasn't officially an addiction or a disorder back then, why was the author drawing these parallels to, say, psychoactive substance dependence?
Because, according to the source, exercise dependence shows features that look strikingly similar to what you see in chemical substance dependence. And the biggest overlap they really emphasize is the presence of withdrawal symptoms and tolerance.
Withdrawal and tolerance. Yeah, those are the classic signs we think about with physiological dependence on substances.
Yeah.
How does the source break those down, and what other components did it identify?
So the source lays out three main components it sees in exercise dependence, making those parallels to addiction criteria. First is tolerance.
Okay.
This means either needing to increase the amount or the intensity of exercise over time to get the same desired effect, or finding that the effects diminish even if you keep doing the same amount.
Makes sense. What's second?
Second is withdrawal. This is experiencing those negative physical or psychological effects when the person stops exercising or cuts back significantly. The article actually uses the Turkish term yoksunluk, which implies that absence or cessation effect.
Interesting. And the third?
And third is compulsive behavior. This is about the repetitive nature of the exercise and how it's often used, maybe unconsciously, as a way to escape or cope with stress, anxiety, or other difficult feelings.
Based on whether those first two, tolerance and withdrawal, are present, the source makes another distinction.
Yes, it does. It uses the presence or absence of tolerance and withdrawal symptoms to differentiate between what it terms physiological and non-physiological dependence, specifically in the context of exercise.
So if tolerance and withdrawal are there,
Then the source considers it a form of physiological dependence on the actual exercise behavior itself.
okay, understanding those core bits, tolerance, withdrawal, compulsion, and that potential physiological link gives us a good base. Now, this is where the source gets really interesting, I think. It proposes two types of exercise dependence, primary and secondary. Let's start with secondary. What does the article mean by that?
Right, so secondary exercise dependence, as defined in this article, is when the excessive compulsive exercise is happening, but it's happening in the context of another primary disorder.
Okay, like what?
Specifically, this source really emphasizes the link to eating disorders. The idea is the excessive exercise is acting as a compensatory behavior, a way to control weight or body shape, and it's fundamentally driven by the underlying eating disorder.
And the source connects this to the female athlete triad concept.
It does, yeah. It describes the triad, which involves disordered eating or low energy availability, amenorrhea, which is the loss of periods, and osteoporosis or weak bones as a pattern sometimes seen in competitive sports, particularly among female athletes.
Right.
And the article even cites some prevalence figures suggesting eating disorders are actually quite common in athletic groups. It mentions around 17% for athletes generally. And excessive exercise can be a major symptom within that eating disorder picture, fitting this secondary dependence description.
So clinically, if someone shows up with excessive exercise and signs of an eating disorder, this source is saying the eating disorder is the main thing to address.
Exactly. That's the clinical implication highlighted. If an eating disorder is present, the diagnosis and the treatment should really focus on that. And importantly, the source is clear that within this framework, secondary exercise dependence isn't defined as an addiction in the same way primary might be, because it's seen as stemming from the eating disorder.
Does it mention any evidence supporting that link between eating disorders and excessive exercise?
It does note that there's biological and experimental evidence backing up that strong connection. And interestingly, it also mentions reports suggesting that this secondary type might actually be reported more often than the primary type.
Okay, that naturally leads us to the other category then. If secondary is tied to another disorder, what is primary exercise dependence according to this source?
So primary exercise dependence, as described here, is where the intense, persistent, and harmful exercise pattern is driven by a psychological and physical connection to the exercise itself. It's not primarily being used to compensate for something like an eating disorder. This is the type where the source feels that addiction concept is most directly applicable. The exercise itself is the focus of the dependence.
And where do the articles suggest this primary type is often seen, or who might be more at risk?
Well, it mentions that primary exercise dependence is seen frequently in high school students. And there's an interesting point about gender. While women might score higher on general exercise dependence scales overall, this article notes one study found the risk for specifically primary exercise dependence seemed to be higher in men.
Huh. Interesting distinction. And what about other mental health issues, psychopathology in general? Where does that fit in?
The source suggests that psychopathological features are more often seen alongside secondary exercise dependence. The view presented is that these often stem from the underlying eating disorder, rather than being inherent to the exercise behavior itself in the primary form.
Right, that makes sense within their framework.
Okay.
Shifting from defining it to actually identifying it, diagnosing exercise dependence sounds like it could be pretty tricky, especially as the source notes, if doctors aren't really aware of it.
Yeah, that lack of knowledge and training among practitioners is explicitly called out in the article. It's seen as a major barrier to getting people diagnosed and treated. Just raising awareness was considered crucial back then.
The source mentions some earlier attempts to lay out criteria, like from someone named Coverley back in 1987. What did those early ideas look like?
Coverley's suggestions, as mentioned in the source, included things like a person's daily life narrowing down to revolve around exercising at least once a day, exercise taking priority over everything else, developing tolerance, needing more exercise over time, experiencing emotional withdrawal if they had to stop, a real subjective focus on exercise, continuing even when injured or told to rest by a doctor, just not wanting to rest.
But the article also points out a potential problem with just using those kinds of observations, right?
Right, exactly. It cautions that relying too heavily just on the amount of exercise could lead to false positives. You might mistakenly label highly disciplined athletes, like elite competitors, as dependent when they aren't actually experiencing the negative consequences or the compulsive aspect in the same pathological way.
Good point. So the source then presents some more detailed criteria, mentioning work by Bamber and colleagues, and notes it was specifically looked at for women. What are the key parts there?
Bamber et al.'s criteria, as laid out in the source, basically had two main parts. First was impaired functioning. This means the person shows loss of function in at least two different areas of life.
Like what areas?
Could be psychological, like constant repetitive thoughts about exercise, anxiety, depression related to it. Social and occupational, where exercise takes over their social life or they can't work. Physical exercising in a way that actually damages their health or causes injury or going against medical advice. Or behavioral, having a really rigid, stereotypical exercise routine.
Okay, impaired function in at least two areas.
Mm.
And the second main part?
The second part is the withdrawal state. This is defined by showing one or both of two things. Either experiencing clinically significant negative outcomes, physical, psychological, social, behavioral, like severe anxiety, pulling away from people, maybe even self-harm when their exercise habits are stopped or changed.
Right.
Or having a persistent desire or making unsuccessful attempts to cut down or control how much they exercise.
And how did the primary versus secondary idea fit into Bamber's criteria?
The Bamber criteria, as the source presents them, explicitly say that if an eating disorder is present, then it should be diagnosed as secondary exercise dependence.
Got it.
The source also lists some other features that often go along with it, but aren't, like, the main diagnostic criteria themselves. Things like tolerance, exercising a lot or at least daily, often exercising alone, feeling shame, maybe lying about exercise or doing it secretly, and sometimes a lack of insight, like denying it's a problem.
Okay. It sounds like the most sort of structured approach discussed for potentially diagnosing primary exercise dependence involved borrowing from other established conditions.
That's exactly what the source proposes as a key way forward at the time. It suggests taking the diagnostic criteria used for substance dependence in the DSM-IV, which was the current version back in 2012, and adapting them for exercise behavior.
Okay, adapting the DSM criteria.
Yeah. Under that adapted model, someone would need to meet at least 3 out of 7 specific criteria over a 12-month period, and those symptoms would have to be causing significant clinical distress or impairment in their life.
Right. Can you quickly run through those 7 adapted criteria they laid out?
Sure, they are. 1, tolerance needing more exercise for the same effect. 2, withdrawal those negative effects when stopping. 3, exercising more or for longer than they originally intended to.
Okay.
4, a persistent desire or unsuccessful attempts to cut down or control the exercise. 5, spending a great deal of time on exercise-related activities. 6, giving up or reducing important social, work, or recreational activities because of exercise.
That impact on life.
And 7, continuing to exercise despite knowing it's causing or worsening a persistent physical or psychological problem, like the classic example of continuing to run despite a serious injury.
And the article mentioned some kind of guide or flowchart for doctors.
Yes, it references an algorithm, basically a step-by-step diagram. It was Şekil 1 or Figure 1 in the original Turkish article developed by someone named Adams. This was proposed as a practical tool to help clinicians work through the diagnosis.
Awesome.
It suggested steps like first screening for eating disorders before even considering primary exercise dependence, and then guiding potential treatment options based on the findings.
Okay. So beyond just clinical observation and these potential criteria, were there any specific assessment tools mentioned in the source, like questionnaires?
Yes, the source introduces the exercise dependence scale 21, the EDS-21. It's described as a self-report questionnaire. 21 questions, uses a Likert-type scale, rate from 1 to 6 or similar.
And its purpose?
It was designed specifically to help identify exercise dependence. And importantly, it was intended to apply across different kinds of exercise, not just, say, running.
How does the EDS-21 actually work, according to the article? What does it measure?
Well, it measures symptom scores across different dimensions related to dependence. Based on those scores, it tries to classify people into categories. Dependent, symptomatic, non-dependent, those are people showing some signs, maybe at risk, but not meeting full criteria, and asymptomatic non-dependent.
Okay.
It also specifically tries to assess for physiological dependence, looking at those tolerance and withdrawal symptoms.
And those 21 questions, they line up with the adapted DSM criteria you mentioned.
That's the idea. The items on the EDS-21 are based directly on those 7 adapted DSM criteria we just talked about. How someone scores on the items relating to each criterion, usually needing a high score, like a 5 or 6, determines if they meet that specific criterion according to the scale's scoring rules.
And the source mentioned it had been validated for use in Turkey.
Yes, it notes a Turkish validation study was done and confirmed the scale was reliable in that specific language and population.
Okay. Beyond the core symptoms and diagnosis, did the source touch on any other related psychological features, like personality patterns seen in people with exercise dependence?
It did, briefly. The source notes a potential link between exercise dependence and certain personality disorders. Specifically, it mentions dependent, narcissistic, and borderline personality disorders as being associated sometimes.
And there was a quick mention of a psychoanalytic viewpoint, too.
A very quick mention, yes. It notes a psychoanalytic perspective that might see this pattern as potentially connected to what they called masochistic narcissistic character development, sort of viewing the compulsive behavior as a pathological offshoot of normal psychological processes.
Interesting. Okay, let's turn towards treatment and clinical monitoring. The article already highlighted that challenge of practitioner awareness. What kind of approaches did it suggest were being considered for treatment back in 2012?
Well, referring back to that Adams algorithm again, the proposed approach seemed to involve a mix of things: education, psychotherapy, and looking at alternative treatment options. The main emphasis seemed to be on therapeutic strategies that address cognitive processes, so how the person thinks about exercise, and also behavioral approaches, focusing on actually changing those compulsive patterns.
And what did the source suggest was needed from the person, the patient, in this process? What was expected of them?
The article outlines several things. The individual needed to accept their role, their responsibility in their own management and recovery. They needed to understand how the dependence was messing with their relationships, their communication with others,
Okay.
and also recognize the intense fear of losing control, those feelings of helplessness, and the kind of disorganized behavior that can come with the compulsion.
And what specific therapeutic strategies or techniques were mentioned?
The kinds of approaches suggested included things like supportive individual psychotherapy to help the person identify and stop the compulsive behavior, guidance to help them understand and appreciate the value of just being healthy overall, not just hitting exercise numbers, empowering the patient to develop their own strategies for managing triggers, helping them understand their own defense mechanisms and how they cope with the dependence, working to resolve the specific triggers and compulsions tied to exercise, and also helping them restructure healthier coping behaviors in general, and strengthening their support systems, family, friends. Education and getting feedback were also really highlighted as crucial parts of treatment.
Okay, so bringing this all together then, based on the author's conclusion in this 2012 review, what were the main takeaways about where things stood back then? The state of understanding.
Well, the conclusion basically summarized that exercise dependence was still seen as a relatively new concept, and it was mostly being evaluated through the lens of existing addiction criteria. It really hammered home the need for practitioners, doctors, therapists to be knowledgeable about how to diagnose it, how to tell it apart from other things, especially eating disorders, and what treatment options might be considered.
And the big ongoing challenge they saw.
The article pointed out that it often stayed hidden, especially, it seemed, within the athletic community, which obviously created huge diagnostic problems for clinicians trying to help.
And the call for the future, back in 2012.
It was pretty clear. More clinical research was definitely needed to build up the evidence base and really deepen the understanding of exercise dependence.
So what does this whole deep dive into a 2012 source really tell us? I mean, it shows that even over a decade ago, clinicians and researchers were seriously wrestling with this idea that a behavior we all think of as positive, exercise, could actually cross a line for some people.
Yeah, that it could cause real harm and show characteristics like withdrawal and tolerance that, really mirror what we see in substance addictions.
It definitely forces you to think beyond just simple good or bad labels for habits, doesn't it?
Absolutely. You have to consider the context, the function of the behavior for that person, and the actual impact it's having on their life and their health.
And perhaps as you've been listening, some of these patterns might sound familiar, maybe in yourself, maybe in someone you know, or maybe it just makes you think about our wider culture around exercise and fitness.
Hmm. This 2012 snapshot gives us a really valuable perspective on how the clinical world was starting to frame and understand this complex issue back then.
And it leaves us with a pretty compelling question, I think.
Yeah.
One that feels just as relevant today as it probably did back then.
Yeah. Which is?
Well, given that this article was written right around the time the DSM-V was being developed, the manual that eventually did include gambling disorder as the first officially recognized behavioral addiction, does the evidence presented here, even from 2012, make a strong case that exercise dependence should be viewed and treated as its own distinct clinical disorder, alongside others?
That's a big question.
It is. And for all of us, maybe on a more personal level, how do we find that balance? How do we navigate that often blurry line between healthy, committed dedication to fitness and the potentially harmful grip of compulsion? Definitely something to think about.